mute, but I think it's about 11:32. I think a couple people may still be joining us, but I think we'll get started if that's okay with everybody. Welcome everyone to our WISH presentation on healthy aging. I can't wait to learn how to healthy age, right? Did everybody get their lovely lunch?
Yes.
Thank you.
Yeah.
Did you get it? Okay, very good. All righty. Just open it up, enjoy it. You kind of shake it a little bit and get that dressing around there and just start in and enjoy. So you've got something to drink. Hi, Judy. You've got something to drink and something to eat and just enjoy it. So anyway, welcome everyone. I appreciate you being here. My name is Suzanne Hensing. I know a lot of you, some I don't, and I look forward to meeting you. I'm the chair for WISH. What I'd like to do is to share with you, we have over about 83, 84 plus people on the call today. It's a wonderful topic. There are a lot of people that want to know about healthy aging. I'm one of them. And so we have a lot of people, a lot of new people. We have quite a few members on the call, but we have a ton of new people as well that we've not had a chance to, they haven't had a chance to join us and we haven't met them yet. So we have so many new guests. I wanted to take, honestly, a very short period of time and talk about 3 simple things. And one of them is I would like to share with you a little bit about WISH and what WISH is about. I'd like to share with you about our future programs. So you have a little bit of an idea of kind of where we're going the rest of the year. And then I'd like to just introduce the program on aging just for a couple seconds. So I'm going to start. I'm going to talk about WISH and it's going to be very short. WISH stands for Women Investing in Science and Medicine. And that's a new name that we just came up with probably about 6 months ago or so. Our mission is real simple. We work with Banner Health and we provide education and philanthropic support. We focus on women and family healthcare issues. It's a real simple mission. We have about 65 plus members and it seems to be growing very rapidly, constantly. We have a board of 9 members, 2 of them are emeritus. And we have an extremely active board and a fantastic board, probably the best board I certainly have ever worked with, and I mean that sincerely. We do presentations every other month. Sometimes we squeeze in an extra presentation and we will be doing that in April and I'll share that with you. At the end of the year, we give back financial support to the speakers who presented to us during the year in a fast pitch format. A lot of fun. The members decide where the money goes. And last year we gave about $250,000 back to the researchers and the presenters that shared their time with us during the year. That's a really exciting event. So that's a little bit about WISH. Our future programs. I'm going to share with you a little bit about our future programs, although you do have this flyer. Remember this little flyer? I think you got it in your lunch sacks. And just want to call a couple things there, call attention to a couple things. On April 15th, which is not listed on the flyer, is a special presentation just for members only. So we'd love for the new people to become members and join us. That presentation is by an expert infectious disease physician. He will be talking about COVID, but not COVID like you've heard and probably attended lots of presentations on. He's going to talk about the vaccines. He's going to talk about how they're made, how they work, the differences between the different vaccines. Will they work on variants or will they not work on variants? And he has access to a lot of this research and where we are in the United States right now with vaccines. Again, it's for members only, but it's going to be fantastic and it's going to be, like I said, a little different than what you've probably heard on YouTube's and the news and all that. So stay tuned for that. On May 6th, we have a presentation focusing on Alzheimer's disease. And the presentation is called Activating Music Memories. And I think it was a couple days ago, there was an article in the Republic about Arizona being the fastest growing state for Alzheimer's in the United States, the fastest growing state. And Nevada was second, I believe, and Mississippi was 3rd. And part of the reason is because we have such a huge number of elderly folks that are moving into, or folks over 60. I wouldn't say we're elderly, but moving into the state. So I think that's going to be fantastic. You're going to hear from Eric Reinman, one of the researchers, top researchers in the world, to talk about Alzheimer's as well. September 23rd, we have integrative medicine that's focused out of MD Anderson, and it'll be really focused more on oncology, an excellent presentation. In November, we'll have an annual fundraiser. We don't have a date yet, but stay tuned for that. Then in December, on December 2, we will have our allocation meeting where we will distribute our money via a fast pitch presentation to the presenters who had presented to us, and that's members only. So that's kind of what we look like for the rest of the year. We try not to have meetings during the summer. Folks are gone, and people want to take a little bit of a break. So we tend to take June, July, and August off. So the third thing I wanted to share about is our program today. And just a couple quick items about our program. It is recorded. I wanted to let you know that because some people like to listen to it afterward, or if they aren't able to attend, want to hear what was presented at a later date. If you have a question, be sure to write your question in the chat area on your Zoom, and I'm sure most of you know how to do that. As you write your question, at the end of the presentation, we will take those questions and then the presenter will answer them for us. So be sure to write those down, think about your questions. Typically this group has a lot of questions and we'll try to get through as many as we possibly can. So before I turn this over to Phyllis Kirk, who is one of our board members and our events chair, she's responsible for this program and all of our programs. She's going to introduce our speaker, but before that, I want to share with you a quote. And I was reminded of this quote because I like Frank Lloyd Wright. I like Frank Lloyd Wright a lot. I'm sure everybody knows him. He was an interesting man, and spent some time in my hometown or my state of Iowa, which I had no idea. I thought he was always from Arizona, but no, he's from Chicago. Anyway, I've always followed him, and one of his quotes I love is, "The longer I live, the more beautiful life becomes." And you know what? I could say that's true. The longer I live, probably the more beautiful life becomes. So with that, I'm going to turn it over to Phyllis, and Phyllis will introduce our speaker to us today. Thank you.
Thank you, Suzanne. Welcome to all of you. We are delighted to have so many people and so many new faces, and we hope that you'll consider joining us in this fabulous group we belong to. We really love providing education to our members. It is the highlight of our mission, and we feel like it's a valuable piece of information that everyone can take something from. Last summer, we started talking to our presenter today about healthy aging and all that it encompasses. And it's particularly important now as obviously our world has drastically changed in the last year. Who would have thought that 1 year later, we'd still be in this mess? And so much of our focus has been on COVID. So much medical research has turned to COVID, but life still goes on, and there is still so much in our own daily health. And so it's to be a very important topic to present to you today. Our guest today is Dr. Jenna Buchanan, and she is a practice physician at Banner University Medical Center, Phoenix. She's also the clinical associate professor at the University College of Medicine in Phoenix. A graduate of the University of Arizona Med School, Dr. Buchanan completed her family practice residency here. She's done numerous activities and positions within the medical field, and some leadership positions that deal particularly with the residency programs. She's participated on the Residency Advisory Board. She's co-chaired the Residency Recruiting Committee. She's co-hosted Family Practice Physicians Journal's podcast. She assisted in developing training courses for residents to enhance skills to manage healthcare teams. Dr. Buchanan was to review program requirements to identify opportunities for program improvement. Her practice here in Phoenix combines both ambulatory care in the geriatric setting, as well as visiting certain nursing facilities or continuing care facilities where they take care of geriatric patients. She's also responsible for the geriatric curriculum for all the residents and medical students. Her interest is the care of geriatric patients, preventative medicine, and clinical education and teaching. Her goal is to bridge access to care, create long-term relationships with patients, and improve education so that patients can make educated and informed decisions about their own health. She's a busy lady. She's got a full practice. She enjoys an active lifestyle of tennis, running, hiking, and she's mom to a young son. Dr. Buchanan, we'd like to welcome you to WISH for being here.
Thank you, Phyllis. Good morning, everyone, and thank you for the very kind introduction. Thank you to WISH for allowing me to speak today on a topic I find extremely important and foundational to my everyday clinical practice. So let's discuss healthy aging. So our aging population has many implications that span well beyond health and the associated healthcare costs. The sequelae of an aging population encompasses older adults that are remaining in the workplace longer, the cost of living with chronic disease, the need for assistance with activities of daily living as we age, caregiving, end-of-life care, and not to mention quality of life. The increasing numbers of Americans over age 65 is rising at a tremendous rate. Currently, more than 51 million people in the United States are over the age of 65, and that number is expected to continue to grow. This has also, this aging population with these increased costs has really changed how we define and treat disease. It's really amplified the dissonance between the experience of living long and what we define health as. Next slide. So we're an aging population, but are we aging in a healthy way? So having disease and being healthy are no longer mutually exclusive, especially for our older adults. Managing multiple diseases is now the norm for older Americans. Approximately 2/3 of adults over age 65 and more than 3/4 of adults over age 85 are managing 2 or more diseases, while at the same time, these same individuals report being in good or very good health. High blood pressure and high cholesterol make up 2 of the most common diseases we encounter, as well as diabetes, arthritis, kidney disease, thyroid conditions, and osteoporosis. These are some of the most common chronic conditions we see. But with regular access to continuous medical care, these and many more can be managed well, sometimes even without symptoms. As we'll see on the next slide, we're going to see how this corresponds and correlates with our leading causes of death that we see here in the US. So the trends we just spoke about, kind of observed in chronic diseases, correlates with the observed trends amongst leading causes of death. As we just saw, 1 in 4 adults has high blood pressure and 1 in 5 adults has high cholesterol, both of which contribute to heart disease as the leading cause of death. In reviewing the leading causes of death, most, if not all of these on this list here, are modifiable or preventable. I've specifically highlighted Alzheimer's disease, as recent evidence suggests that individuals with heart disease, diabetes, and now obesity may be more predisposed to developing Alzheimer's disease. You may note that this data is from 2010. Current data as of January 2021 shows that COVID has now surpassed all of these and is the current leading cause of death in the United States. So how do we define health? Historically, the World Health Organization has defined health as a state of physical, mental, and social well-being in which disease and infirmity are absent. But based on what we previously discussed regarding the prevalence of individuals living with disease and living longer, is this definition realistic or really all-encompassing? The definition of health may need to be thought of in a more comprehensive manner, which incorporates disease prevention as well as chronic disease management throughout the lifespan. And I would suggest to you or kind of imagine that amongst all of the individuals here joining us for today's lunch, I would guess everyone has kind of their own individual definition of what health means to you. So as we look at the next slide, kind of what makes up health or what contributes to health? And as discussed, health is a really complex interplay of multiple factors that include individual aspects, things such as our genetics, behaviors, the environment, the healthcare system, and socioeconomic status. Managing multiple diseases, maximizing function, optimizing medication regimens, prioritizing different health risks and outcomes, and preparing for end-of-life considerations are just some of the areas that deserve to be included in our basic definitions of health. So let's talk about risk factors that kind of go into or kind of may affect our own health. So on the next slide, we're going to talk about things that we need to consider. On the previous slide, we discussed many factors that comprise health, kind of that what we call social determinants of health, or factors that kind of affect our health. Some of those you may have noticed are things that are non-modifiable. These are factors that we cannot change no matter what, things such as our gender, our race, our genetics, etc. And as we think about modifying our risk of developing chronic medical conditions and resulting disease that may compromise functionality, we really must think of strategies to not only detect disease, but delay their onset or identify them early in their most treatable stages. As we kind of progress through this presentation, I'm going to focus really on these factors that you see here on this slide. We're going to talk about routine screening recommendations and guidelines, immunizations, as well as risk factors and things that we have the ability to influence. Before I progress, we're going to talk a little bit about the recommended screening guidelines. Something that in my role as a primary care physician, I've really noticed that this has been impacted significantly by COVID as patients have delayed or offset care, kind of delaying it to a future date in terms of not wanting to be seen by their physician for routine care, for wellness exams, or even management of their chronic diseases. So these are things I find really important. So let's talk about screening guidelines. Many of you have at some point in your life undergone routine health screening tests, but how do you know when these tests are indicated? How frequently should they be performed? And what happens when a screening test comes back abnormal? It's really important to clarify that screening tests are just that. They're screening tests. They are designed to detect disease in an asymptomatic individual, so that someone without symptoms or concerns for a particular disease or illness. These guidelines are put forth by many governing bodies, such as the United States Preventive Services Task Force, the American College of Obstetrics and Gynecologists, and the American Cancer Society, just to name a few. All of these guidelines are based on clinical trials and data, and they're really intended to provide recommendations to patients and their physicians to answer some of the questions I just posed. While most of the guidelines are consistent across governing bodies, there are some discrepancies which may make it challenging for patient and provider alike to help navigate. And as we discuss the recommended screening guidelines, I'm going to focus on the guidelines put forth by the United States Preventive Services Task Force, which I'll going forward refer to as the USPSTF. On the next slide, we're going to start with breast cancer screening. So breast cancer screening guidelines may be the most controversial of all the guidelines we will discuss today. There are conflicting guidelines across governing bodies regarding the best age to start screening, as well as the frequency of screening. I know this is a very confusing subject, not only for patients, but physicians alike. From the USPSTF, current guidelines recommend screening mammography every 2 years for women aged 50 to 74. This may be a little bit of a shift for some of you who are used to screening starting at age 40. This has been a recent change in recent years to move the screening back to age 50. For women aged 40 to 49, that decision to start screening can be an individualized one and should be discussed with your physician. That decision to start screening earlier really should take into consideration the potential risks of false benefits. So anytime we look at a screening test, we should know what is the potential benefit. So that's detecting disease or detecting it at an early stage in which it's treatable, and then weighing it against the potential harms. And in this case, it's really the harms of false positive results. And while screening mammography in women aged 40 to 49 years old may reduce the risk for breast cancer death, really the number of deaths averted is small, and it's much smaller than that in older women. And the number of false positive results we see in this age bracket can oftentimes result in unnecessary biopsies. Ways to reduce the risk of developing breast cancer includes routine screening, maintaining a healthy weight, and regular exercise. Excess alcohol intake is linked to an increased risk of breast cancer, as is the use of hormone replacement therapy after menopause. And really, that's just to name a few. There are far-reaching other risks, as well as things that we can do to kind of mitigate those risks. I'd like to segue into cervical cancer screening. Current screening guidelines recommend routine cervical cancer screening with pap smears in women aged 21 to 65. Screening occurs at various frequencies based on age, certain risk factors, and results from previous pap smears. With normal screening, recommendations suggest screening every 3 to 5 years based on age. In recent years, the intervals between screening have increased. So what was previously done every 1 to 2 to 3 years is now done every 3 years for women aged 21 to 30, and then every 5 years for women aged 30 to 65. This increase in the interval between screenings really also is coinciding with a continued decline in the number of new diagnoses of cervical cancer that we're seeing. And we really attribute this to not only the increased screening, but the recognition that the human papillomavirus causes approximately 91% of all cases of cervical cancer, as well as the initiation of the HPV vaccine series, which was introduced in 2006. On the next screen, we're going to talk about colorectal cancer screening. So most US guideline organizations, including the USPSTF, recommend screening for adults aged 50 to 75. This guideline is currently being revised, and we anticipate new recommendations to begin screening for colorectal cancer starting at age 45. There are various ways in which we can perform this screening. Traditionally, this has been done with a colonoscopy or a sigmoidoscopy, procedures that are performed by your gastroenterologist. In recent years, we've seen kind of the advent of new screening tests that are done at home. So FIT test, the FIT test, or the Cologuard test are also substitutions for this. Colorectal cancer screening done via colonoscopy is recommended every 10 years if screening is normal, but can be done every 3 to 5 years, depending if precancerous polyps or red flags are identified during that screening process. The stool tests, commonly referred to as the FIT or Cologuard tests, are typically performed annually, with the caveat that if these tests come back abnormal, we do recommend patients undergo further testing with colonoscopy. Recent data has shown that ways to reduce the risk of colorectal cancer include routine screening, smoking cessation, limiting alcohol consumption, and regular exercise. Being overweight or obese increases your risk of getting and dying from colon or colorectal cancer. And diets are extremely important here. What we found with colorectal cancer is that diets confer either a protective benefit or can increase the risk of developing colon cancer. So specifically, diets that include vegetables, fruits, and whole grains have a lower risk of colon or rectal cancer. Red meat consumption has been linked with an increased risk of colorectal cancer. Let's shift now and focus on cholesterol screening. So cholesterol screening guidelines recommend that adults aged 40 to 75 be screened for high cholesterol. They don't typically give a recommendation in terms of the frequency in which we are screening. So typically it's done every year to every several years. We know that elevated cholesterol, as we spoke about kind of at the beginning of the presentation, may confer an increased risk of cardiovascular disease, including heart attack and stroke. To reduce the risk of high cholesterol, important considerations include smoking cessation, as well as regular exercise, which has been shown to increase HDL, or what's also known as the good cholesterol. Dietary modifications may include reducing saturated fats. These are fats that are found in red meat, full-fat dairy products. Also eliminating trans fats. These are fats that are found in store-bought cookies, crackers, cakes, kind of the processed foods. And then really focusing on increasing soluble fiber in the diet through foods such as oatmeal, kidney beans, Brussels sprouts, and pears. Evidence shows kind of a mixed take on omega-3 supplements. This also goes by fish oil supplementation. Really, evidence does not show a benefit for heart health or reduce our risk of stroke or death from any cause. With that being said, I know this is a bit of a controversial subject, and patients that I see and patients in the community are still on omega-3 supplementation, oftentimes to attempt to reduce any sort of cardiovascular risk related to high cholesterol. As we move from screening, let's talk about vaccines. And vaccines really are the most important tool that we have to prevent disease. So just as important as detecting disease is really preventing it with routine vaccinations. And while vaccines are administered at various ages and are targeted to prevent a multitude of diseases, I really want to specifically address the influenza and pneumococcal vaccines. Combined influenza and pneumonia infections were the 7th leading cause of death in the US in 2010. And both influenza and pneumococcal vaccinations have been shown in several studies to reduce the severity of illness in people who get vaccinated, but who oftentimes still get sick. Current recommendations for influenza vaccine are for anyone aged 6 months old and older. So annually this is done. Pneumococcal disease includes pneumonia, meningitis, which is an infection of the brainstem and the brain itself, as well as bloodstream infections. There are 2 types of pneumonia vaccines, which makes it really challenging for patients and providers to provide recommended guidance and to make sure that patients are up to date on these vaccinations. Currently, adults aged 65 and older are eligible for a one-time pneumococcal vaccine. That's the 23-valent vaccine. Individuals aged 19 to 64 with certain medical conditions, including chronic heart, lung, or liver disease, as well as diabetes, smoking, and alcohol use disorder, are also eligible for a one-time vaccine. These individuals will require revaccination again at age 65, and that's a one-time vaccine that's given. The 13-valent vaccine, which used to be given at age 65, has now shifted, and recent recommendations have suggested that patients can forego this vaccine given the decline in the number of infections we're seeing related to these various strains. So kind of a shift in what we're seeing now. It's just the 23-valent vaccine starting at age 65 for most healthy adults. So I'm sure I must have sounded very repetitive as we've discussed the common threads, kind of risk factors associated with various disease. You may have noticed similarities, including diet, physical activity, and lifestyle choices that have been pervasive amongst the various diseases we've talked about. And given the importance of these, I would like to spend some dedicated time reviewing each in further detail. So let's talk about physical activity, or kind of, in our case, physical inactivity. Despite the documented health benefits, less than half of all adults get the recommended amount of physical activity. Results of various studies continue to support a growing literature that suggests that exercise, physical activity, and physical activity interventions, things such as Tai Chi, balance interventions, yoga, and then strength training, have really beneficial effects across several physical and mental health outcomes. Participants in clinical trials of physical activity interventions show better health outcomes, including better general and health-related quality of life, as well as better functional capacity and better mood states. So really the importance of physical activity cannot be overstated. A recent trial, which I think is very important to discuss, is something called the Life Study Trial. This is very pertinent to the patients I see in my practice in the long-term care or continuous care communities. This study showed that the ability to walk without assistance is critical for older adults to continue to age in place and maintain function. Really important. The study also showed that a regular, balanced, and moderate exercise program reduced the risk of major mobility and disability. The current recommendations are for 150 minutes of moderate intensity physical activity per week, otherwise known as kind of 30 minutes, approximately 5 times a week is another way to look at that. The recommendations don't give kind of specific guidelines as to what constitutes moderate intensity physical activity. Things that I like to specifically address with my patients would be yoga, balance exercise. Tai Chi has really good evidence behind it in terms of preventing future falls, reducing the risk of reducing the risk of using or having falls, and then reducing the risk of needing assistive devices such as canes or walkers as we age. For lots of people as we age, we tend to see arthritis or obesity tends to limit or prohibit certain types of activity. So we need to consider activity modifying interventions for things like that, using pools, low resistance, recumbent bikes can be a really good tool to incorporate that type of physical activity per week. For patients who are a little bit more physically active and who can tolerate high intensity physical activity, The recommendation is for 90 minutes per week, although I do tell patients it's really important every day to do some sort of physical activity that gets your heart rate elevated. And I think more than anything, it really creates that pattern of getting into the routine of physical activity becomes such an important part of our daily routines. Let's talk about obesity. So obesity continues to be described as a global pandemic. In the US, over 40% of adults and 18% of children are obese, which I think is striking. This is defined as having a body mass index greater than 30. And obesity has serious implications as it is associated with poor health and mental health outcomes and reduced quality of life. It's associated with most leading causes of death in the United States and worldwide, including diabetes, heart disease, stroke, and some types of cancer. And I think what's interesting to note from this slide is that 80% of obese adults suffer from diabetes, high blood pressure, coronary artery disease, high cholesterol, and arthritis. It really tends to be probably the most common risk factor for the chronic medical conditions that we're seeing in our patients. It truly is a complex health issue that results from a combination of causes and individual factors such as behavior as well as genetics. And behaviors can include physical activity or inactivity, dietary patterns, medications can certainly contribute to this as adverse events, as well as additional or other exposures. Other contributing factors include the food and physical activity environment, education and skill level, socioeconomic status, and food and marketing promotion. And then managing and treating obesity is really just as complex. There's several ways in which we target obesity and have attempted to help our patients with this. Recent trials and data continue to support dietary modifications truly as the most beneficial of the interventions. On this slide here, you'll see other things that have been proposed, such as diet-related medications are certainly gaining some traction. There's 4 medications currently approved by the FDA to treat obesity, but what we know and what we've seen from studies is that weight loss is minimal. On average with these medications, patients lose approximately 12 pounds. And then the data in terms of long-term weight loss sustainability has not really been proven. Oftentimes patients will, at the 12-month mark, will regain or will not have lost the weight that we've expected. There has been a trend in recent years for patients with extremely elevated BMIs, specifically BMIs over 40, to really push patients towards bariatric surgery, given that at this point we know that the risks of certain correlated or comorbid conditions, such as the high blood pressure, coronary artery disease, and diabetes, are really important. And treating with surgery really tends to be the best chance at managing all of those conditions at one time. Along those lines, I'd like to talk about high blood pressure. So as we saw kind of in one of the first slides, high blood pressure represents the most common disease in the United States. As we age, this becomes approximately half of men and women in the US over the age of 55 have dealt with or are dealing with high blood pressure. The definition of high blood pressure really varies, and it varies from governing body, and it also varies based on age and the presence of additional medical conditions. For patients who have other associated medical conditions, such as diabetes or kidney disease, really targeting a lower blood pressure is really important to maintain overall health, as well as maintaining good control of kind of all of these correlated diseases. We know that undiagnosed or untreated high blood pressure increases the risk of heart disease, stroke, kidney failure necessitating the need for dialysis, as well as blindness. This is a disease that is really kind of a silent disease. Most patients do not know or do not have symptoms that can alert them to the fact that their blood pressure is elevated. So we really rely on routine follow-up and screening with their primary care physician to help detect high blood pressure. Once detected and once diagnosed, there are various options to help manage high blood pressure. So these include dietary changes. The most studied have been salt intake, so limiting sodium intake to less than 2,000 milligrams of salt per day. Focusing on dietary changes, and probably the most studied and the diet with the best evidence behind it would be the Mediterranean diet. as this has a high rate of kind of unsaturated fat intake, focusing on the good and healthy fats. Physical activity, we can't overstate the importance of physical activity. And we've shown that, increasing physical activity levels just above kind of normal activity baseline really can help lower blood pressure. And then once we make these dietary changes and implement physical activity, if we're not able to control patients' blood pressure with these kind of what we describe as conservative measures or dietary and lifestyle measures, then we can initiate various medications to help us lower that blood pressure to kind of below our target goal. And then once we see that patients are under control, studies have shown that the benefits truly are striking. Lowering the blood pressure even slightly, so lowering it by 12 or 13 points can reduce the risk of heart attacks and strokes by up to 1/3. And then all deaths from cardiovascular disease can be reduced by up to 1/4. So really important. Let's now shift and talk about smoking. So smoking still to this day, which is kind of alarming, remains the leading cause of preventable death in the US. And it contributes to 1 in every 5 deaths. Currently, approximately 15% of the population in the US is smoking cigarettes. And while we don't see a large population of that here in the United States, or in Arizona, if we look at the map here of the United States, really we see a continued trend in the Midwest and the Southeast of the United States. You may recall from previous slides and looking at the map of trends in obesity, this really correlates, and we could almost overlay these maps to show that cigarette smoking and obesity are very closely linked. So, with growing trends too, we're starting to see the use of electronic cigarettes and vaping, and we will likely to continue to see long-term health consequences going forward from cigarette use as well as the use of electronic cigarettes and vaping. And not only does cigarette smoking increase the risk for lung cancer, which is probably the most common cancer it's linked to, but it has been linked to 17 other types of cancers. And we know that it increases the risk of coronary heart disease, stroke, and other chronic respiratory conditions such as emphysema, asthma, COPD. Quitting smoking is something that we deal with every day in our clinic and can be quite challenging. When we counsel patients on smoking cessation, really there's kind of a two-prong approach, which is replacing the nicotine, so curbing that nicotine addiction, as well as replacing the habit with something. So certain medications are currently approved in the US by the FDA to help us with smoking cessation. Those medications you may be familiar with include Chantix. So Chantix is one that we use, as well as a medication called bupropion. It also goes by the name of Wellbutrin. While using these medications, we use them for several months at a time. We also then plan to have patients using some sort of nicotine replacement to help replace that habit of smoking cigarettes kind of throughout that day. And nicotine replacement comes in various forms. We can use it as a patch, lozenge, or gum. So using these together over time can help aid in patient smoking cessation efforts. This is one of the hardest things for us to assist our patients with, and it's something that we revisit kind of frequently. I oftentimes will tell patients that the biggest predictor of success with smoking cessation is the number of previous attempts that they've had. It really kind of, I think, goes to show that patients who are dedicated to quitting and who attempt to quit kind of no matter how many times are the ones that in the long run are the most successful. In recent years, we have seen kind of the advent of other resources, and here in Arizona, we're lucky to have the Arizona Ash Line. So this is a 1-800 toll-free number that all patients can call. It's 24/7. There's counselors on the other end of the line, so patients can talk with smoking cessation counselors and coaches to help them with their smoking cessation efforts. They can also help provide medications. So oftentimes if patients talk with a counselor and decide on starting a medication, I will then get an order sent to me from the Ash Line, co-signing or approving the medication that the patient has approved. So this is a wonderful resource that we're privy to here in Arizona. And then as we kind of talk about alcohol use, this is something I think that we'll see a little bit more focus on going forward. And really, because alcohol use or unhealthy alcohol use is still an under-recognized, it's a still under-recognized risk factor for a variety of health and social outcomes. And the definition of what constitutes unhealthy varies, but is generally recognized as more than 2 alcoholic drinks per day for men and 1 per day for women. Alcohol intake above recommended guidelines is clearly associated with increased mortality and other medical comorbidities. And then our understanding of its health effects, both suggested cardiovascular benefits and medical harms, remains limited. You may have heard of the thought that red wine or having a glass of wine a day may confer some cardiovascular benefits. And the data there is mixed. And I mean that in the sense that we're not sure if it's related specifically to the alcohol or to the wine or an ingredient in alcohol, or if it's related to other activities or healthy lifestyle habits that those patients are doing. So at this point in time, it's important that we recommend to our patients, for men, no more than 2 drinks per day, and for women, no more than one drink per day. Depression is something that we're starting to recognize commonly, and we see it not only in our younger patients, but we're starting to see it as what we call late life depression, or our patients who are entering into adulthood, or even our geriatric patients. It's very common. It's a very serious health concern that is associated with comorbidity, impaired function, excessive use of healthcare resources, as well as increased mortality. And we're starting to see that our older population of men in particular are at increased risk of suicide and make up a large portion of our patients that pass away from suicide. Late life depression remains underdiagnosed and inadequately treated even when we do diagnose it. The risk factors for depression are multifactorial and include female sex, having a history of anxiety, low self-esteem, substance use, and adverse life events. In terms of thinking about why this is under-recognized or inadequately treated, I think part of the reason why is that depression can oftentimes mimic other physical symptoms. So depression can manifest itself in various physical ways. We oftentimes will see it as poor sleep, fatigue, weight gain or weight loss, changes in appetite, poor concentration, or even not wanting to engage in activities or hobbies that they used to, which I think makes it very challenging for patients to not only discuss with others as well as their providers, but for providers to recognize and really address. The topic of healthy aging really is broad and extends far beyond what we were able to cover in our discussion today. To summarize the recommendations for healthy aging, remember to discuss all of these options with your physician. And there's options to detect and prevent disease, including disease screening performed at routine intervals, as well as appropriate vaccinations to prevent disease. Various opportunities exist to modify risk factors for developing and managing chronic medical conditions. And lastly, please be aware that aside from your physician, there are various resources that you can access for free to assist with your goals toward maintaining a healthy life. I have listed some of the resources available to you here. Many of these resources are underutilized, and they provide information and assistance for healthy aging, as well as resources for those who take care of family or friends who are aging. At this point, I hope a lot of you have questions, or if there's anything I can help clarify, I'd be more than happy to go into that at this time.
Myself. So great, we're getting some questions being sent in by our members and their guests. So I'm going to read them to you, Dr. Buchanan.
That would be great.
A lot of the age groups that you mentioned did not include over 74. So some of the questions relate to recommendations on screening for people over 74, such as breast cancer screening. What tests should be regularly scheduled for that age group?
So good question. So as many of you have picked up on, our screening recommendations for breast cancer and colon cancer stop at age 75 and 74 respectively, and cervical cancer screening stops at age 65. And I think the reason is, as our population ages, we don't have studies or data to show us what the risks and potential benefits are of screening in an elderly population. We do anticipate that some of these recommendations will shift going forward as we start to notice that our patients are living longer. So at this point in time, even though there's not a true hard and fast cutoff, if you are over the age of 74, over the age of 75, I think it's worthwhile having a discussion with your physician about the potential harms of screening. So that may include unnecessary tests, biopsies, further testing, as well as the benefits of screening, which would be, detecting preventable disease, as well as diseases that may, impact our longevity or quality of life. I personally, as I'm seeing patients who are over the age of 74 or 75, we have a pretty frank discussion about life expectancy and what it means in terms of, is it important for us to test? And if we do test, then what are we going to do about either an abnormal test or a normal test?
Shingles. We didn't touch on shingles at all, and the shingles vaccine that is currently available. One of our members, they had the vaccine 15 to 20 years ago. Now there's a new one out with 2 doses. Should I consider being revaccinated?
Yes, I would say you should absolutely consider being revaccinated. So the previous vaccine was called Zostavax. It was a one-time dose that was given after the age of 50. We know that the protective benefit, it was about 70 to 75% effective. The new vaccine is called Shingrix. It's a 2-dose series starting at the age of 50. It can be given to anyone who has or has not had shingles in the past, as well as anyone who has been previously vaccinated with Zostavax. So it's given as a 2-dose series. After you receive the first dose, it's given 2 to 6 months after that. So one-time series, 2 doses, I would absolutely recommend redoing it. It is important to note, kind of along the lines of vaccines, with the COVID vaccine out now, the recommendation per the CDC is to get no vaccines within 2 weeks of each other. So certain COVID vaccines are given as a 2-dose series. Both the Moderna and the Pfizer vaccines are given as a 2-dose series. Pfizer is 3 weeks apart, Moderna is 4 weeks apart. We anticipate in March seeing the Johnson & Johnson vaccine, which is a 1-dose series, and then going forward, potentially the AstraZeneca, which is a 2-dose series being approved here in the US. When getting the COVID vaccine, we do recommend that if you are planning to get other vaccines such as flu, shingles, or pneumonia, you do wait 2 weeks in between any sort of vaccine. So important to talk with your physician about the timing and when you're going to get those vaccines.
Good information. If you've had pneumonia in the past 2 years, when should you get a vaccine?
I'm sorry, can you repeat that?
Yes. If you've had severe pneumonia in the last 2 years, when should you get a pneumonia vaccine, a pneumococcal?
Good question. So the pneumonia vaccine should be given regardless if you've had pneumonia or not, starting at age 65, and that specifically is the 23-valent pneumonia vaccine, otherwise goes by the pneumococcal vaccine. If you have other medical health conditions such as heart disease, lung disease, diabetes, you're on dialysis, you're a smoker, asthma, have any other lung disease, we do recommend a one-time series between the ages of 19 and 64. That is then repeated at age 65, as long as there's been a 5-year gap between the first dose and the second dose. When you get the pneumonia vaccine at age 65, it is not repeated. It's just a one-time dose. There used to be a 13-valent, as I had mentioned. That is now kind of a shared decision-making with your provider, but the recommendation is currently not to vaccinate adults over the age of 65 with the 13-valent. The 13-valent is the one that is administered to children. So within the first year of life, it's given to children in a 4-dose series.
You talk about COVID vaccine and mammogram. Should I delay mammogram?
So that very good question. I think this is something that we're seeing often in our clinic. Patients are delaying routine screening tests in light of everything going on with COVID. I think specifically screening centers, breast centers are minimizing the risk of COVID, and they're using enhanced precautions to make sure that patients are safe. If you are due for routine screening, I would recommend going through with that if you have not been able to get the vaccine. If you don't have any symptoms and you would like to get the vaccine first, I think that would be something to discuss with your physician. But providers in my clinic and myself, we're still recommending that if you're due for a routine screening, whether it's mammography, colon cancer screening, that we go ahead and ensure that we do that regardless of the timing of your vaccine. On that note too, with the COVID vaccine, there are very little contraindications, meaning things that you would preclude you from getting the vaccine. So the CDC has said things such as chronic medical conditions, autoimmune conditions, being on a blood thinner should not stop you from getting the vaccine, and nor should it interfere with the vaccine itself. So it shouldn't diminish the efficacy of the vaccine or of any medications you're taking. If you have a severe illness or are currently ill with COVID, they do recommend delaying the vaccine. They haven't given a specified time frame in which we recommend that delay. Patients who've had COVID and who have received a monoclonal antibody infusion for COVID to prevent severe infection are recommended to wait 90 days after that infusion before receiving the vaccine. And the thought is that if you've had COVID, the immunity that you've received from having COVID would protect you for anywhere from 3 to 6 months is how long we anticipate antibodies to last. So there is a thought that delaying getting the vaccine up to 90 days after you've had COVID may be beneficial and may allow individuals who have not had COVID a chance to get vaccinated.
Okay. Can you talk about bone health, and osteoporosis prevention?
Good question. So this is something I didn't get a chance to touch on during my presentation. So bone health, especially as we age and especially in females, is very important. Current screening recommendations recommend screening starting at age 65 with it's called a DEXA scan or a bone density scan, where we specifically look at bone health as it relates to other women and other individuals in your age bracket and with your kind of health conditions. There are exceptions to this screening starting at age 65. So individuals who have potentially autoimmune conditions, who have been on long-term steroid use, or who have previously suffered a fracture that are concerning for more of an osteoporotic type fracture should be screened earlier and more frequently. The frequency in which screening is done is dependent on kind of your overall bone health at the time of initial screening. In terms of osteoporotic prevention or preventing osteoporosis, probably the biggest thing is physical activity. Diet doesn't typically confer any sort of protective benefit, but physical activity, especially weight bearing, so things like Tai Chi, balance, all of the things that also can prevent fall risk are really important in bone health. There are medications that we use for those who are in the osteoporotic category. So things such as bisphosphonates can help. There are other medications that can be used kind of once yearly or injectables that are new and are oftentimes used for patients who have other underlying medical conditions.
Okay, next question was enlarged lymph nodes from the COVID vaccine. What are the indications for that and what causes that?
This is not something I'm overly familiar with. I would have to go back and look at the studies to see if individuals are experiencing kind of enlarged lymph nodes. Anecdotally, I have had one patient tell me about enlarged lymph nodes that resolved shortly after the vaccine. But in terms of kind of long-term effects, I think we're currently in what we call phase 4 trials, in which we're following patients who have received the vaccine to see if there's any sort of long-term risks or side effects that we're noting. This is a novel, the mRNA is a kind of a novel way to create disease, and the thought, or to create vaccines. And the thought is that mRNA is not something that lingers in the body long term. It's degraded very quickly and shouldn't interfere with the DNA that we have in our cells, which I think is why this is felt to be a very safe vaccine. But in terms of specifically the enlarged lymph nodes, anecdotally I've seen it, but haven't seen kind of large studies discussing that that's a risk for or from the COVID vaccine.
This is a really important question someone brought up, and I'm a chocolate lover. So what are the benefits and or risks of chocolate?
In terms of specific benefits, I would say, I think there has been some data shown that chocolate, specifically dark chocolate, does have some cardiovascular benefits. I think additionally some stress reduction benefits too. I think side effects would be, if it's not eaten in moderation, I think that would be something to take into consideration. Just everything with moderation, but there are some benefits, and I certainly partake in my fair share of chocolate, as my mom can attest.
So when you say moderation, what's the cutoff point?
Oh my goodness. So I would say, that varies by the quality of the dark chocolate. I would limit it to a small square or two a day. So if you have a candy bar, breaking it up into, quarters and eating it over the next few days, I think would be ideal.
Okay,
Not a scientific answer, but yeah.
great. How about hormone replacement recommendations? So you talked about that being a risk factor in the development of breast cancer. And there's been lots of studies and lots of controversy. What is the latest on that information?
So you're exactly right. Hormone replacement therapy is something that is very controversial. It varies from provider to provider in terms of comfort level with this. In terms of why hormone therapy is used, oftentimes we use it for women who are in kind of the perimenopausal or menopausal state, which I'll define. Perimenopausal state is kind of that period of time leading up to women going through menopause. Menopause typically in the US occurs in women starting at age 51, and this is a clinical diagnosis. So menopause is defined and diagnosed in women who have not had a menstrual period for 12 months. Once you have had an absence of a menstrual period for 12 months, we consider you menopausal. Any bleeding or spotting that occurs after that 12-month period in which menstrual periods have ceased is abnormal and should be reviewed further with your physician. Oftentimes, as we go through menopause, there's a shift and a change in hormonal levels, specifically a decrease in estrogen levels. This can lead to things such as vaginal atrophy, which can cause urinary incontinence, stress incontinence, difficulty with libido, painful sexual intercourse. It can also lead to things such as hot flashes, things that we refer to as vasomotor symptoms, so hot flashes, sweats, weight gain. The idea behind hormone replacement therapy is to kind of re-provide some of those hormones that are lost during that time frame in order to address specifically things such as low libido, decreased vaginal tissue or atrophy, as well as those vasomotor symptoms. The idea behind hormone replacement therapy is really to use it for kind of that duration that we anticipate menopause to last. That typically is 7 years from the time menopause is diagnosed. So after that time frame, we would anticipate kind of weaning or backing off hormone replacement therapy. And hormone replacement therapy is not dosed based on hormone levels. So there really isn't a benefit in terms of checking someone's hormone levels. Even after they're menopausal, it won't help us in confirming the diagnosis of menopause, and it won't help us titrate or adjust hormone replacement therapy. That is oftentimes done based off of symptoms alone. The risks of hormone replacement therapy, that we know that it can increase the risk of breast cancer specifically, as well as the potential risk of ovarian cancer. So in talking with your physician, I would certainly, kind of like anything we spoke about today, it's really looking at the risks versus the harms of being on a medication like this. In recent years, there's been some additional studies looking at other treatment options to kind of help mitigate some of those side effects that women experience during menopause. And that includes using medications such as antidepressants off-label to help with some of those symptoms, and then trying to use like a topical estrogen therapy to enhance vaginal tissue health, which may help with urinary incontinence as well as pain with sexual intercourse. That was a very long-winded answer to a very good question.
No, I appreciate it. Okay, I think we have time for one more question. And one of our members had asked about sleep in healthy aging and the importance of sleep, which is probably a very big topic to talk about, but if you could.
You're right. So sleep is certainly important. And as we age, we know that our sleep patterns shift and adjust. What we typically see in younger patients as we kind of have restorative restful sleep as we enter through various stages of sleep throughout the night, typically getting into what's called REM, or that restorative phase of sleep every 90 minutes or so. As we age, that period of time becomes further and further apart, and our time in that restorative sleep becomes shorter and shorter, leading to kind of what we call delayed sleep onset. So it's oftentimes difficult falling asleep and then staying asleep. And then coupled with things such as having to get up at night to urinate due to bladder concerns or urinary incontinence can make sleep very disrupted and very disjointed. So sleep is something that as we age is certainly very, very important. How we address and manage sleep is also very complex in that there are medications that we can use to help, but most of the medications that we use are oftentimes used for their side effects of sedation. So the medications can cause sedation or can help with that sleep onset, but may not necessarily help with that restorative sleep or with getting patients into that deep restful sleep. Things that have been studied that have really shown benefit would be mindfulness. So using phone apps, keeping phones, TVs, anything that has a blue light out of the room. And then if you're not able to fall asleep, getting yourself up and out of bed, doing something to distract yourself or kind of removing yourself from that situation to avoid thinking about sleep, and then returning to the bed at a later point in time to try again. We oftentimes will recommend maintaining the bedroom for sleep and sex only to really create kind of a restorative, safe environment for sleep. And then counseling, specifically CBT or cognitive behavioral therapy, has gained some traction in recent years in terms of helping patients develop sleep techniques in terms of keeping and staying asleep and then feeling well rested the next day. There is a subset in medicine, sleep medicine, in which patients can discuss their concerns with a sleep medicine specialist and oftentimes can undergo sleep studies to see why or what's contributing to unrestful sleep.
Okay, well, we're out of time on questions. Dr. Buchanan, we really want to thank you for your time today. Lots of really valuable information and a lot of information. So we'll be able to get this out to our members and send some more questions to you that once you answer, we'll be able to email them to our members. Also, Suzanne has a few closing remarks.
All right. Thanks, Phyllis. That was fantastic. Thank you, Dr. Buchanan. I took copious notes here. I wanted to acknowledge one thing, and you don't have to comment on it, but I bet other people on the call were thinking of this as well. 1 drink for women and 2 drinks for men per day. And I tell you, most of my friends might be surpassing that, especially during COVID right now. So I just wonder, and it's not really a question, just a comment, what the long-term effects, healthcare effects of COVID will be on our population. So with that, just curious. Thank you for joining Women Investing in Science and Health. We love our organization. This is an example of some of the presentations that we have. We'd love for you to join us. And I thank you today for being with us, and have a lovely day. Thank you so much. Bye-bye.